Thank you, Mr. Chair. Thank you, Administrator, for being here. I think we all share the common ground of lowering healthcare costs and especially shoring up hospital safety nets. And without appropriate protections that stem from costs from charity care, access is impaired and everyone's healthcare costs go up. I want to talk about the Medicaid Disproportionate Share Hospital Program, the DISH program. It's an example where we provide very transparent payment to hospitals that do provide that charity care. Our healthcare system is complex, it's highly regulated, but the DISH program goes around this by directly giving straightforward payments to hospitals that are doing the good work of serving patients without coverage. Unfortunately, this is often, this program has been cut in favor of other priorities like the Affordable Care Act, and it's been cut as a budget gimmick. Now, we've kicked the can down the road by delaying those cuts for years and years and years. I'm proud to partner with Congresswoman Clark on bipartisan legislation to create a fully paid-for 2-year solution to Medicaid DISH funding, which covers the cost of safety net hospitals that treat these at-need uninsured populations. Avoiding these cuts also in a way that is more fiscally responsible. I just want you to comment on that and underscore how important the DISH program is. I mean, which hospitals bear the brunt of potential DISH cuts?
As you were mentioning, so many of our safety net hospitals are the ones who would lose payments according to DISH, because DISH really focuses on hospitals that serve a disproportionate share of uninsured or Medicaid beneficiaries.
Yeah, so I'm going to assume that you would agree that we should probably not cut those in the future.
I would say that it is very important that we maintain coverage for safety net hospitals.
And do you agree with the assessment? I mean, the Affordable Care Act's cuts were problematic for these healthcare safety net programs.
I would say that it is important that, particularly as we still have uninsured in the country, to make sure that hospitals are paid for caring for them.
Yeah, I mean, I want to point out for the record, I mean, one of the problems here was that the DISH cuts did come from the ACA. There was a miscalculation of how many Medicaid enrollees would be in the program. Doesn't matter if it was an expansion state or a non-expansion state. I mean, Ms. Clark is helping me lead this, obviously, and that's New York. So the last question I have, do you agree that DISH payments are an accountable and direct mechanism with which to subsidize hospitals? And as we rethink incentives in the system, could DISH be a good model for transparency when we do need to support hospitals in need?
I do think that DISH is an incredibly important program and way of really understanding who is serving
That's an important program, but I mean the framework, the way it's actually
I would agree
administered.
With you that
do you think it's a good model?
I think that there is a lot of wisdom to having some understanding of what the payer mix looks like in terms of payment.
I want to talk about primary care access in the Medicaid program. Simple question. Do you think there's a physician shortage, and where do you see that most pronounced?
I would agree with you that we are seeing workforce challenges, and it's not everywhere, but it's in so many of our rural areas. And you mentioned primary care. We absolutely have a lack of primary care in many parts of the country.
Yeah. I'm introducing bipartisan legislation that would seek to open access to independent primary care physicians in state Medicaid programs, particularly through recurring preset payments. We call that direct primary care. And I'm doing this because in too many parts of my state and throughout the country, actually, there's a shortage of primary care physicians to serve this critical population. The patient-to-physician ratio in rural areas is 39 to 100,000 people compared to 53 to 100,000 in urban areas. And boy, we're looking to have a shortage in the United States of as many as 55,000 primary care doctors. So I think this is very important legislation. I urge my colleagues to support it for obvious reasons. Access to primary care reduces emergency room utilization, improves outcomes, probably reduces overall healthcare spending. We often talk about getting people access to coverage, but that isn't care. I think this legislation could go far in allowing states to experiment with their own Medicaid programs. There's no question in there, but if you have any last remarks or positive things to say about that, go ahead.
Just to agree with you that it is crucial that we do more to support primary care in this country.
Great, thank you, and I yield back.